Welcome to Oncology Revolution, where science meets care to transform the cancer journey. We explore evidence-based strategies to enhance quality of life, promote longevity, and empower patients and professionals to thrive beyond cancer.
Welcome. Thank you so much for joining me, Arif. I'm really excited for this conversation. You've obviously had an amazing career, both academically, professionally, on the past few years. Can you please tell us about yourself? Like, who are you and what is your why?
Yeah, my why. Well, I think fundamentally, my why is about being a bereaved son. So, my mom was diagnosed with breast cancer when I was very young, and it was formative in my career, not only in wanting to be an oncologist, but also in wanting to focus on the experience with cancer, not only for the patient, but the caregiver as well. Having played that role as a caregiver and watching an experience that was, well delivered in some aspects, but also components of it where I wondered, could it be more compassionate? Could it be a bit more patient-centric? Could it be more comprehensive in understanding the sources of distress that people commonly go through? Was what drove my career. And so I pursued actually a palliative care fellowship before I did oncology work. And so it gave me a perspective really sort of nested in compassion and patient centricity as I went into oncology training. So it changed sort of how I looked at, the utility of a bone marrow biopsy in a person who's dying, for example. It helped me understand the risks and benefits and opportunity costs of providing chemotherapy in the last 2 weeks of life, right? And understanding also the humility that goes along with our ability to prognosticate and our ability to understand, certainty and uncertainty, and really the importance of communication in talking to people who are going through a difficult journey. So, became a professor at Duke and started an outpatient palliative care program within the Cancer Center, and that's been my clinical practice. And then now at the American Cancer Society have been the inaugural chief patient officer, where my role is to oversee the patient programs that the organization has globally, with the idea that we would be centered around this idea that we are going to bring compassion and reduce suffering in the work that the organization does. And that's been my leadership style, is to center around that. And the operating model we've had is really a very simple formula that compassion equals empathy plus action, right? Empathy is important, but without action, you can't lead to compassion. And so as a compassionate, let's say person, clinician, but also in my leadership, leading an organization that strives to be compassionate too, it means that we have to understand the experience of others. That's the empathy, both in quantitative, qualitative, and lived experiences ways. So we have to be humble and open and in a growth mindset to kind of try to understand the experience of shoes we're not walking in, but then match the action to that empathy so that you understand, for example, if someone's cancer journey is leading to food insecurity, that the right action might be to help them access food, both in terms of adequate food and nutritious food, right? But historically, we have thought about oftentimes action first and then hoping to sort of retrofit the empathy and the compassion to that. I'm just trying to change the formula around. And so I think as we've become more compassionate, maybe as healthcare providers, and certainly with the string of palliative care in there, it means we've started with empathy first, then allowed the action to show itself. So it might be that the empathy is that starting to understand that people who go through a cancer experience, while we might hope that they have really rich social networks and a sense of belonging and connectedness during that journey, that the data would show us that for many people, their social networks actually fade away, that their sense of connectedness might get fractured, and that might show up as social isolation or loneliness, and that actually the right action to take might be to create social connections between an isolated or lonely cancer patient or their caregiver and networks around them that they may not have. And that is embedded, for example, in the concept of palliative care. We've been doing that for a long time, but making that mainstream into the delivery of cancer care, I think, is relatively new, but a trend we absolutely need to get behind because we're starting to appreciate what actions need to be taken when we understand the empathy that's needed.
Yeah, thank you. It's really some simple things that can indeed change how we look at this. And if we try to guess what people need, we won't probably be meeting all their
That's right.
needs.
Yeah, that's right. That's right.
And this also reminds me of a quote that you have, I think, on your LinkedIn banner or something, that the American Cancer Society exists because the burden of cancer is unacceptably high. And this is not only in terms of incidence and death rates,
Yeah.
but also on all these aspects of survivorship throughout disease.
I think that's important to recognize that people have goals beyond life prolongation. And I think for a long time, we've, overly simplified the goal of cancer care. And I see a duality of more and better days. And I see a false choice to pick one or the other. I think that, palliative care's ethos, but really it should be the ethos of cancer care delivery itself, should be to facilitate more and better days. Now, the idea of more is nested in the reality of whatever someone's going through. So more might be days, weeks, and months for some. It might be years for others, and it might be a lifetime for others. And better days also requires similar definitions as well. So for some people, better days is more time with their grandchildren. Better days might be more time playing the piano. A better day might be being free from pain. And so I think that part of the humility of the practice of oncology and palliative care and its intersection is being curious as to what that looks like for others. Because the reality is that while no two people are the same, we recognize that no two people's definitions of more and better days are generally the same either. And I think that when we practice, we find that to be true. I've met 90-year-old people who tell me have chemo in my veins until my last dying breath. And I've met 20-year-olds who say, I don't want any chemotherapy at all because I want to spend what time I have left feeling good, not in the cancer center, and with my children. And I think that while we might have our own judgments about the wisdom of either of those choices, the reality is that the story of cancer is not ours, right? The story is of the patient and the caregiver, which means is that the story is theirs. The only person that can determine whether something is right or wrong ends up being the patient and the caregiver. And it's hard as clinicians to not be judgmental or to not at least silently have judgment because we have our own sense of right, wrong, and justice. We also have our own very good understanding of science and possibilities. We have our own heuristics. We have our own experiences of what works and what doesn't work. I think one of the hardest things about being a healthcare practitioner today is recognizing that uncertainty is not a solvable problem. We cannot solve for uncertainty. We know that a person with lung cancer can have a Pt.1 expression of 99% and not respond to a Pt.1 drug. It baffles the mind that that's true, but yet it is true, right? And so our certainty around a companion diagnostic or predictive test and then prediction to the treatment, solving that to 100% certainty is not something that's, I think, going to happen imminently anyways, which means we always have to be able to communicate uncertainty to a person who is looking for certainty. That oftentimes a patient with cancer is looking for, tell me what is absolutely 100% true. That will never be solved for. And so that means that our duty as clinicians will always have a complexity to it, which will be to talk through things that we hope and wish, that we want, and that the only certainty that we can get to is not going to be on the treatment side. It's going to be on understanding someone's values, wishes, and preferences, because those are things that people intimately know if we ask them to share it with us. And so there are ways to hold both things to be true at the same time, which is that we can't certainly tell you the outcome on the cancer side, but I can certainly tell you that what we will do to take care of you will align with your goals, values, and preferences. And I, as a clinician, am committed to understanding what those are.
It is something that we in oncology can learn from palliative care, right? And traditionally, from the Cicely Saunders or the first models of palliative care, where we had like a more interventive treatment on kind of a box or silo, and then it would finish abruptly, and the palliative care would come in for the end of life. And now we're
Right.
evolving more like a on and off model as it
Yes.
needs to be, right?
Yeah, and I think that evolution also reflects that, you know, prognostic-based referral criteria
Mm.
to supportive services, whether that's specialty palliative care or just enhanced supportive services provided by the oncology team itself, you know, are a historical approach, but are not a modern approach. And what I mean by that is if one could only predict that someone who is stage 3 has more concerns than someone who's stage 1, like while that heuristically might be someone's experience, my clinical experience tells me that there are people with stage 1 breast cancer who are so can't, are so awash with anxiety and concerns about cancer recurrence that they need the TLC of of a palliative care approach, whether it's delivered by specialty clinicians or the oncology team. I've seen that, and I've seen folks with stage 4 cancer who are on oral therapy and don't have a ton of needs that one needs to address. So I think that taking someone's prognosis or stage and extrapolating what their needs are is an unrefined instrument. I would say it's kind of a blunt instrument to be used. I would rather say that we will treat individuals as individuals, assess them comprehensively and regularly for palliative care or supportive needs, and then to your point, like a roller coaster, kind of dip in and out as people have those needs. Because just as we talk about hope as a dynamic construct, that someone who's a teenager might hope to get their driver's license, someone who's in their 20s might hope to find the right person to marry, hope to have a healthy child, et cetera. That hope is a dynamic construct, and so the hopes of a person who has 2 weeks left to live will be different than a person who has two years or 20 years to live. That hope is a dynamic construct. So is suffering, and so is need, and that hope can move up and down over time. So can suffering, and so can need. And that regular assessment can lead to the targeting of the right services throughout the course of someone's continuum of illness. And we really need to see it in that dynamic way. To your point, it's not a yes, no, when they're stage 4, we will do this. And I think that's been the evolution that palliative care has been on for, really the past probably 10 years at most. And evolution will continue to have to happen. And examples are even care delivery mechanisms, not just referral. So if we think about the classic example of hospice being, limited to someone who's actively dying or having 6 months less to live, that is too limiting. Because what we find, right, is the palliative care as a concept was born out of this idea that why can't someone get this if they have a year left to live? If it's such good service and help people in such nice ways, why not do it more upstream? Well, if you keep pulling on that thread, the upstream starts to become to the point of where we want it to be, is to the point of the time of diagnosis of a serious illness. And that's where we are now. But in implementation, we still have some work and some room to grow.
And we do have evidence that early palliative care can improve survival ultimately, right? From at least 15 years now.
That's right. That's right.
Why do you think that we are still not implementing it? And I'm not specifically speaking about very specialized symptom support or symptomatic palliative care, but even for patients in a very, very early stage of life-limiting illnesses, we know there's a role for advanced care planning, for support of their carers that can also come on an on and off basis and have an impact throughout, like the whole journey of disease.
Yeah, I mean, it's a complex issue. I think, what I mentioned about not having solved for uncertainty means it's a challenge. And I think that, healthcare and the definition of a good doctor, a good nurse, a good practitioner, there's an identity change that is happening that one has to accept for this to work. And what I mean by that is if you believe that you went to medical school and did residency training, fellowship, all these things to bring scientific certainty to a person in need, and that your role is to play this certain confident fixer of problems, and that is how you see yourself in a monolithic way, then you will probably actively avoid conversations that introduce uncertainty, vulnerability, and sort of scientific gray. And I say that because it's not easy to take on an evolving identity as an oncologist, which is one that says, maybe I don't know what's going to happen. I hope that this is what's the outcome. Maybe there are things beyond biology that affect someone's experience and they are worth asking about and addressing. And that maybe there is a lot of value in conversation and presence and silence, as much so, if not more than therapeutic certainty and verbosity and filling the space through word. And I think for some clinicians, that transition from the know-it-all scientist to the compassionate listener and healer is easier for some than others, and maybe a generational change that occurs as well. Because the great part about innovation in cancer care is we have more drugs, more targets, better understanding, more sophisticated definitions of, I say this all the time. Oncologists are bad marketers. When we found lung cancer and we looked at it under a microscope, when the cells were small, we called it small cell lung cancer. And when the cells were large, we called it either non-small cell or large cell, right? We're not the best at naming things. And then what happened is we found, molecular drivers and these targets, genomic and so on. And now we have at least 50 different types of lung cancer that we can define. So that's the beauty of scientific advancement. But what we did not solve for is that we can look a person in the eye and say with 100% certainty, if I do this for you, you will 100% be alive 5 years from now. We just can't do that. And so I think that as this transition happens, it's less important for oncologists to identify themselves as chemotherapists, right, as the givers and the key holders to therapy. And I think this broader definition of healer means that we will address people who have concerns about, not only the biology, but survivorship, pain and symptoms, emotional issues, interpersonal issues, the other things that are going to come up. And that's going to happen in a team approach. So an oncologist might say, great, I want to focus on just what's the right therapy, but my team is going to recognize that there's other aspects of the journey that are important to take care of and to appreciate. I think we're on the path there. I have a ton of confidence of where healthcare is going, because I think that the appreciation, even scientifically, that, we have good evidence, for example, that someone who doesn't have a partner or primary caregiver is going to have worse outcomes with cancer than someone who does. Why is that? It's not a biology-driven mechanism. That is a socially driven mechanism that will manifest itself in compliance with medications, asking the right questions, anticipating the right side effects, calling us when they see them because the caregivers are eyes and ears. So you now start to pay attention to the caregiver, someone's home environment, their access to the basic necessities of life, and it becomes naturally a part of the conversation that when you're healing someone, you have to be paying attention to those issues. I think that healthcare is understanding that, but it had to go through phase one before it could get to this phase. Because if you don't have the privilege of many treatment options to choose from, then there's no time to think about food insecurity or loneliness or caregiver resilience. Because at that point, the biggest issue is we just don't have treatment. So we need to focus on coming up with treatment. But if you're a breast cancer patient today and you have at least 8, 9 therapeutic options in the adjuvant setting, right, then it is not the fundamental problem of our time is not about availability of treatment. It's not, because I just told you, you've got 8, 9 treatment options. It's about accessibility to that treatment. So it's not availability, it's accessibility. And accessibility is a function of solving all these other issues: transportation, lodging, caregiver support, financial toxicity, that those are paramount to accessibility. Accessibility then leads to availability being solved for. And when oncology was first started, the whole challenge was availability. Now I think when you've got 11 treatments, 12 treatment, 13 different treatment options, while some orphan diseases still have an availability problem, for sure, some of our bigger, more common cancers, it really is an accessibility issue. And that is the transition that's happening in the delivery of care, which means there's a transition that needs to occur in how clinicians identify their highest and best use.
Indeed. And it touches all those parts of the patient, like holistic life or context
For
that we
sure.
need to be aware of. You've also touched on how important it is for us to look at the patient's priorities and preferences. And this reminds me of the PROs, or how we need to be assessing like the patient's reported outcomes routinely, both in clinical practice and clinical research.
Yeah.
What are your thoughts here? Are we already doing enough, or do we still need to implement this more widely, or even using better tools that capture different nuances?
Well, yes. I mean, I think there's some things we're doing well. So I'll start with, I think this transition towards need-based consultations and referrals to palliative care is the evolution that we needed. So it's evolving from prognosis-based referral criteria to needs-based referral criteria. So that evolution is taking place. But it is operationalized not always in the best ways. So to your point, sometimes it's a one-time PRO, but it's ignoring the fact that needs are dynamic. And so, I do think that comprehensive approaches that are also regular are very much needed. To the issue of comprehensiveness, I think sometimes right now it's operationalized as focused on very specific physical needs like symptoms. But really, when you think about total pain, which was Cicely Saunders' concept, and we think about total dyspnea and total suffering, right, is that I have, for example, run into a patient. It was a real patient I took care of, ovarian cancer with peritoneal disease with significant abdominal pain. I saw her, assessed her, and prescribed an opioid pain medication. Had her come back in 2 weeks to assess the efficacy. She comes back 10 out of 10 pain. So I talked to her about the regimen and how often to take it and to keep a diary, so on. So send her on her way. She comes back 2 weeks later, still 10 out of 10 pain. What I recognized I had failed to do was a comprehensive assessment of things like her spiritual history. So I asked her, the questions we might use in clinical practice, like, tell me about your what gives you hope and strength when times are tough, right? Sort of a spiritual question. Tell me about any important religious or faith traditions that guide your experience with serious illness. And, are you at peace? A really great one question. I failed to do that. And the reason I bring that up is because on the third visit, when I did that, she shared with me her feeling of guilt and atonement that some transgressions early in her life, she thought that the cancer diagnosis was God, in her religious tradition, punishing her for those transgressions, such that the experience of pain is part of the atonement process for her in this experience of cancer as a punishment in her religious tradition. Now, her faith tradition and mine were not the same, nor would I see that was my expertise. So after recognizing that, I had her, talk to my chaplain colleague through that to understand, right, wrong, or indifferent. My job was not to pass judgment or have an opinion about whether experiencing 10 out of 10 pain is the right thing for her to do. Actually, the humility of being in our role is we have to say, that's not what I would do, and that's not what I believe. But this story is not about me, right? It's about her. What was interesting is after she talked to my chaplain colleague, she worked with her priest, which was her religious leader, through this to come to a conclusion, which was that that is not how she was going to be comfortable moving forward, which is she would feel comfortable actually taking pain medicine. So what changed is me doing a comprehensive assessment and then providing the right. So this was the compassion equals empathy plus action. My empathy was, tell me more about your experience as a person in this particular faith tradition. Then the action was going to be to bring in a chaplain, and that was going to be my demonstration of compassion to her. Fundamentally, then down the road, she took pain medicine. Her pain score did go down. Now, she did eventually die of her disease, but I could feel good that instead of passing judgment, because I think if I had said, well, when my understanding of your faith tradition or reading your religious book, that's not how I would interpret, right? Like that would be passing judgment. That would not have gotten us to where we needed to go. That me being open-minded and providing the action, which was a chaplain, got her to where she was. And so that's an example where a comprehensive assessment uncovered something that, and it was through my own failing. I didn't do the comprehensive assessment. So the humility in that is recognizing, oh, right, this is important to do even from the very beginning. So I think that getting to comprehensive is really important. The other area that I would call blue ocean, right, is that there's not definitive answers around, or I would say regular practice is, what does it look like to provide a comprehensive assessment of need to the caregiver that is both operationalized in conjunction with the patient? So you might ask the patient and the caregiver together, how is your home experience going? Do you both feel supported? You can ask these questions that can be done together, but also then hold space for this idea that the caregiver should be assessed for their concerns and needs and wants, potentially separate from the patient themselves. Because if done that way, you might very likely uncover some needs or opportunities that the caregiver has that they may feel shy to talk about in the presence of the patient. Because it's very clear, as a caregiver, you can feel both extraordinarily privileged and honored to serve in that role and fulfill a sense of loyalty and duty and love and care and friendship. And at the same time, acknowledge this is really hard work and I am stressed and burnt out and at my wit's end and I feel alone and even potentially unappreciated for the work that I'm doing. And that you could hold both things at the same time is actually a common thing that I find in my clinical practice. And so to this issue of comprehensive longitudinal assessment, we should not forget that the caregiver is their own person and has their own life and concerns and so on, and that we should evolve our practice to figure out, how do we do that in a respectful way to the patient? How do we identify the role of an oncology or palliative care team in its sense of duty to a caregiver, which sometimes can seem in conflict? For example, if you see your role in a billing, transactional, financial relationship to the patient, then you might see the discussions with the caregivers being tangential to what is a primary duty to the patient. So there's even a defining of the relationship. Now, I think in specialty palliative care, we have defined our relationship to the unit, which is the patient and caregiver. But I don't find that in most of healthcare outside of palliative care, if someone said to an oncologist or a cardiologist, who is your duty to? I think they would say it's to the patient. I hope the caregiver's talking to their primary care physician about what's on their mind, but my duty is to this one person. And I think that even starting with identifying that the duty of a serious illness practitioner is to both, starting there, and then what does that look like once we've established that, whether it's an assessment, a conversation, a dedicated time and attention to that person will naturally manifest from first identifying this duty part.
Yeah, I agree. It is a challenge, even in terms of like protective, like space or resources or time.
Absolutely. Right.
Everything.
Right.
You've touched the suffering of the patient and the caregiver, but like burnout is also very common for professionals, both in oncology and palliative care. And you've spoken about this on different platforms, and you said something like we need to change the environment. So we cannot totally protect people from these exposures, but we can question how the environment can help protect them or thrive.
Yeah.
Yeah, I would love to hear more about this.
Well, I think part of it is there's a selection bias of people who go into specialty palliative care. That's been my experience. And that selection bias is on a continuum of everything I've seen from, passionate professional interest to deep personal interest to a justice-based lens of like, I'm here to fix healthcare. And the data that we have from the US anyways, is that about half of people in specialty palliative care came from another specialty. And at least in the US, it is not a financially lucrative thing to stop being an intensive care doctor or an oncologist and come be a palliative care doctor. It's not generally a positive financial move if financial motivations are your only motivation. So one can extrapolate that for a lot of people that are making that transition, there is a deeply personal or professional sense of change and being a change agent that they want to be a part of. Because in many ways, we think of palliative care as a movement, and a movement needs change agents within it. And if you see the lens of palliative care from a social justice lens or a healthcare transformation lens, right, that there tends to be a self-selection for people who are at least minimally deeply passionate, all the way up to a sense of martyrdom. And I don't mean in the death sense, but martyrdom is in, I will give everything I have for my patients, their caregivers, and the system that needs changing and transformation. And the problem is you can give everything you have, and that is admirable and maybe what is needed. But you can't take a cup and empty it, turn it back over, and then expect it to magically be full again and empty it again. And so that means you have to take the time. When you think about this is the Frank Starling curve in the cardiology world, right? You have to have, reduction of afterload, and you do have to have some preload to have, an ejection fraction, right? And even the heart, which is a highly efficient muscle, does not operate at an ejection fraction of 100%. It doesn't work. And it does not work without afterload reduction. And if you have, hypertension, right, on the arterial or on the arterial side, like that's going to cause a problem. And so if you take that analogy to what we're talking about, right, you have to have afterload reduction, which means that you have to think about the system with which people operate. If there are many barriers and friction from the practice of medicine, everywhere from documentation, billing, you tell someone you have to see this person in 10 minutes, right? Like the system can provide afterload, all right, pressure against which you're working towards, right? And so you have to think about the system. The way the American Medical Association says they kind of use the 80-20 rule, which I think is pretty good, which is that if you look at the stresses of healthcare, about 80% of those are process and system issues, and that 20% might be interpersonal and personal opportunities. And I think that it's way too convenient to say that the burned out clinician just needs to do more yoga. I mean, that's sort of an overly simplistic way to look at it. And while I think that individual pressures and work-life balance and things like that are important for maybe 20% of the time, we can't lose the perspective that you can give an inotrope to try to make a heart beat harder. But if you do not have afterload reduction, because you have very systemic arterial pressure, like you're working against yourself, right? So you have to have a little bit of both. And so I think you have to improve the system. Now, I think palliative care clinicians, as I started with, I think are somewhat unique because there is a sense of martyrdom there that may be a little different than cardiologists or oncologists. Like oncologists are passionate groups of people, as are cardiologists. I generally don't hear someone say, I left intensive care to become an oncologist because there's so much injustice in oncology. Like you just generally don't hear that. You hear generally passions like my mom had cancer, so I became an oncologist. Like, and that's laudable for sure. But that sense may be a sense of legacy, pride, change. But generally, most people don't say, people get terrible oncology care, so I became an oncologist. I think what they're saying is cancer is a terrible thing and I want to help. I want to help it. That is a slightly different motivation than a martyrdom-based motivation, which is the system stinks and I'm here to fix it. Because the challenge is one person cannot generally change the system. So it's like having a to-do list where you can't actually check all the boxes, right? So what happens is you have to, I think, check the boxes that you can, then go home and come back and start checking the next set of boxes. And so I think that there's an intentionality that's required for all clinicians, but I think in palliative care, because you're there to fix injustice and you will not do that overnight, that there is a measured incremental approach that you have to take. And it looks at taking things one day at a time, one consult at a time, one goal at a time, moving forward. I also think it takes a sense of community, because the challenge of injustice, if that's what you're trying to solve, is generally you can't solve it as an army of one. And what we found in some of our data around burnout is we particularly see burnout higher in clinical persons or teams who do not feel connected to others. Because the work is hard, and talking about the work being hard can be therapeutic in and of itself. Because as we say in clinical practice of palliative care, presence and connection is important, even if you can't fix it. There are plenty of things in oncology we can't fix, but the therapeutic presence we believe is important. Now, what is the therapeutic presence for each other? Even though we can't fix all problems, being together is helpful. I will tell you that as a clinical team in the team that I am a part of, we recently lost a very long tenured advanced practice provider to a cancer diagnosis. He died of cancer. This was, somewhat unusual because we were normally talking about other people. We were talking about ourselves. And what we found very helpful in a very dramatic example is that we return to the principles of palliative care: connection, therapeutic presence, not being able to fix all problems, understanding that suffering exists, but that connectedness will help, being humble to that all problems can be solved. Those principles helped us through something that we were not accustomed to. And so I think that as we think about those principles, they should apply to us as team members, because they work when we're talking with patients. They clearly work when we're talking about ourselves as well.
It is curious that you mentioned that, because it's also what research, for example, on trauma from major catastrophes seems to show. Like when it's something that involves the whole community, as everyone comes together to kind of get over the catastrophe or the problems that arose, people seem to do better than when it's isolated incidents that affect one isolated individual rather than the whole community.
Yeah. And it's seeing resilience as a skill, not an inherent trait. And what I mean by that is not only like genetically inherent trait, like people aren't sort of born maybe more resilient than the others. I think one is the human condition is so interesting because our ability to predict our resilience in the future is not that great. I mean, there's really good data to demonstrate that people with, chronic kidney disease stage 3 who are being counseled about the future possibility of hemodialysis, that people maybe pre-event have a sense of what that's going to be like. And yet we find that the human condition is oftentimes quite resilient when it goes to meet the moment. That many people who would say in their 30s, I would never sign up for a 3-day-a-week, multi-hour intervention that will make me extraordinarily tired and tie me to a machine. I would never want that. We find that actually that doggedness oftentimes disappears when faced in that moment itself. That while there are people who choose not to do hemodialysis, and that's a really important discussion to have, most people faced with that would say, I think I could be resilient through that. I didn't think I could, but now that I'm faced with it, I can. But it involved conversations and scenario planning up front, but also in the moment sort of working through it. And I think that for, the clinical teams, I think it's hard to anticipate that. And I certainly do not want people to think of it as a trait. And as I was talking about earlier, self-selection, I think there's this myth that the people who do palliative care must either enjoy or be inherently resilient to others' suffering. And that's why we choose to do it. Right? Like, oh, you must really enjoy talking to people about their dying. And I'm like, well, why would you think that? Well, you do it all the time. And I was like, well, yeah, I do it because one, I think I'm good at it. Two, I believe that someone should do that. And I've decided that that someone could be me. But I don't accept the fact that someone who's dying should have no one talk to them, right? So that's where we are. But to the issue of like, do I enjoy doing it? Am I differently resilient from someone else in doing it? I don't know that that's true. So there has to be an intentionality in saying like, well, it's hard and we need to talk through it and build the skills around it. I think, my good colleague, Joe Rotella, who was the previous chief medical officer of the American Academy of Hospice Palliative Medicine, I've heard him talk through this and say, being present and a witness to someone else's suffering is like standing next to a waterfall and thinking you're never going to get wet. You will have splashes of a little bit of water hit you, right? And because there's an outpouring of suffering that's happening, you are a witness to that suffering. How some of that is not going to stick to your clothing doesn't make any sense. And I would extrapolate that analogy to say, it's like saying that everyone's standing next to the waterfall, but the palliative care clinicians are in waterproof wetsuits. Why would you think that? There's nothing magical about being a palliative care clinician. No one handed me a wetsuit when I started in the role that says I'm not going to get wet. Of course I will. I'm wearing the same clothes that everyone else is. I may be standing a little bit closer, actually, to that waterfall than some other clinicians or members of the team. And so it is natural to think I will get a little wet. It is also natural to think that when that happens, what will I do to dry off? So we're not arguing about whether wetness, whether that will occur or not. What we should be talking about is like, well, how does one dry off from that? Because the issue is if you have to dry off from that and go stand next to the next waterfall 10 minutes from now, and then 30 minutes from now, go stand in the next waterfall, how do you then create the system that allows someone to transition from one waterfall to the next and have some moment to dry off either in between or at the end of the day? And maybe even how does one do that together with a sense of community?
Connected to that, you've also mentioned that we need leadership to look at staff well-being and have incentives tied to that. How do you see this being connected to value-based healthcare, or how we have healthcare organized?
Yeah, well, I think there's a palliative care principle in this, right? We ask people like, what's important to you? What do you value the most? And people are like, I don't know, Dr. Kamal, that's a hard question to answer. That seems very like ethereal and hypothetical. At the end of the day, people value what they spend their time on and what they spend their money on. So if you tell me that your dog needed an ACL repair and you spent $7,000 on that ACL repair on your dog, it's probably reasonable for me to extrapolate that your dog is important to you, right? Sort of a dramatic example, but my point is I've had patients say that to me and I'm like, oh, so your dog is important to you. And they'll be like, well, yeah, he's okay. And I'm like, well, hold on. Well, you just told me a story that tells me that he's more than okay. So I think that the way we spend our time and the way we spend our money tells us what's valuable to us. So as a leader, if I say that someone's, workplace resilience and emotional health is important to me, but I create financial incentives for myself as a leader and for them as an employee that tie money to not things related to resilience and burnout, then there's a incongruence, right? So for example, I would ask, how many senior leaders in a health system have their incentive tied to the well-being of their workforce? Now, there are some, but there are others that tie their financial upside to the revenue of the health system. Well, then you just told me what you value, clearly. Oh, no, we value the well-being of our workforce. Great. So then in the report card of the evaluation of the leader, is there a metric related to employee engagement, turnover, burnout rates? Like, give me that and then show me it's important to you. And then second is, I know what you value by how you spend your time. If you tell me you spend 2 hours a day playing the piano, it's safe for me to conclude that you value your ability to play the piano, which means that if I give you neuropathy by giving you a taxane, that I affect the thing that is important to you, right? So that we could get from that. So if you tell me as a leader, you really value resilience and reduction in burnout, and I ask you, what are you doing? Oh, once a year we have a 1 hour session on personal resilience. Well, you just told me how you spend your time. So now you told me how you spend your money or how you gain your money and how you spend your time. So that can't possibly be true. You may want that to be true, but that's not actually true, because how you spend your money, how you spend your time is how you objectively, demonstrate your value. So my encouragement to leaders is, if this is a priority to you and you value these things, look to see how this is expressed in compensation, evaluation of performance, even talent attraction, how you might recruit people onto your team, how you might separate them from your team, and then how you spend your time and how you allow the team to spend their time. So for teams, for example, that do debrief sessions, Schwartz rounds, ad hoc times together, formal didactics around resilience, who have open door policies with leaders to talk about the difficulty of the work, right? Like, when you create time and space and energy to do it, and you have incentives around it being done, then I fundamentally believe you. And when you look at high functioning organizations, you will find these two things to be true. You will absolutely find leadership incentive tied to these values, and you will find financial incentive tied to these values, and you will find time dedicated to these values. You will find that those who go through, examinations for certifications of being high functioning organizations, if they don't put this into place, it doesn't matter how high performing they are, they will not, from an impact perspective, they will not get from good to great, if you will, without solving for this issue.
Thank you. This more like organizational or leadership view ties nicely with the corporate and entrepreneurial also mindset that you have. And I would love to ask you, also you co-founded Prep Health to support seriously ill patients and caregivers. What gaps did you see, and how does technology helps filling them?
Yeah, I think that, palliative care and some of these supportive care issues are going, again, from an availability to accessibility issue, right? So, availability was like, what is palliative care? Should we start teams? Where do we put them? Do we have enough of them? Da, da, da. Similarly, now where we have this accessibility issue is like, what's the referral criteria? How do we have enough of them? How do we protect their time in the right way, and so on? And so I think when we think about technology as a facilitator of scale, it's a facilitator of not only scale, but scale of patient centricity. So in my work at Duke, the idea was to create scalable technologies that increase patient centricity around these topics of supportive and palliative care. So for example, decision aids or engagement facilitators, educational aids, things like that for people who might need palliative care to be demystified or to help make decisions between clinical trials or standard of care. And so in these moments, tools that extend the ability of the clinical team to have that conversation by having a tool do that conversation with someone. Now, in today's day and age, that would be AI, is how we get to accessibility. Because the challenges still remain. At least in US-based polls, 95% of people still don't know what palliative care is. What's sobering around that statistic is when the Center to Advanced Palliative Care did that survey 15 years ago, the number was like 97%. I mean, we've had very little movement in public perception of palliative care, despite the fact that we've grown the infrastructure for the clinical delivery of palliative care. And as healthcare becomes increasingly consumerized in multiple different ways, that patient choice and acceptance is a part of this. I mean, healthcare is much less paternalistic or maternalistic than it was before. I mean, it used to be people said, "Hey doc, what should I do?" And if the doc said, "Go to palliative care," they said, "Okay, great," and they would go. Now, people, while the doc says you should go to palliative care, will pull out their phone and Google it just as quickly before the sentence is even finished and make up their own impressions of what it is. And if it starts with a Wikipedia page about how it's end-of-life care only, well, you can start to see what the challenge is, right? So engaging people at the moments that they want to learn and understand about this thing that they may or may not want to do or have preconceptions around ends up being the reason why we develop some tools. And I started a company, not to get wealthy, to be clear, but to create a dissemination mechanism. And you're starting to see that in other parts of palliative care. So when people are doing like creating, they're manualizing a therapeutic intervention for a palliative care context. And what they're saying is, now that I've created a manual, I want to disseminate that manual so that other people are able to do it too. And the limitation of an academic publication is the manual, the app is not in the publication. I wish it could be. Like, I wish the Prepped Health app was the appendix to the article about how our PC for Me app can reduce the no-show rate to palliative care clinic because people fundamentally understand what it is and now will come because we demystified what it is. But that's not how the world works. The paper is the paper. It gives you the data. So we created a company to help disseminate that. But I encourage others, it's not so much the story of Prepped Health, but I encourage others in the field of palliative care too, find a problem that's worth solving, create a solution to that, but then don't write a paper and then walk away. Because academic papers have rarely solved suffering. What they've done is they've drawn attention to the suffering, they've maybe proposed what the intervention could be, but they didn't put the solution in the hands of the patient. Papers don't do that. And by the way, patients don't read our papers either. So I think all of us think about, what does the implementation step look like? In my case, it was creating a commercialized strategy to do that. But for others, it might be a manual. For others, it might be a training. Think about what is needed to get to scale. And where we started in this conversation is 15 years ago, we identified that palliative care might, improve survival. But, we didn't really get to change off the New England Journal of Medicine paper. It started a conversation of, well, great, now how do we actually do this? Because if you're at a very large academic medical center with the resources of what they had in Boston to do that work, for example, like, okay, great. But then the next challenge is, how do you get that to work in a town of 20,000 people in a rural area? And then, so the next phase of that work, for example, from that group was to figure out whether telehealth could be non-inferior to in-person delivery. Because once that was proven, the telehealth was non-inferior, now you could get to accessibility and scale in a way you couldn't get to before. So I think right now, that's what we're trying to get to, whether that's through technology or other methods.
Well, thank you. We were briefly discussing the barriers earlier, or why palliative care was not coming into practice more widely, or was not so widely available. And at least here, our reality in Portugal, and I think in Europe, people are more aware of the concept of palliative care, but there are lots of misconceptions. So it is associated with end of life. So we kind of feel that we need to come up with another term or refer patients to, say, give it another name, supportive care, something else to jump this barrier. And then it will make sense once they get there and see what it is, and they will probably feel at home or in peace with that.
Yeah, I think, we've used terms like extra layer of support, the umbrella before it rains. I mean, people have used different analogies of that. I think I very simply say to patients, it's the care that you deserve at the time that you want. And I think it gets to two issues. One, people have this sense of what healthcare should look like. And from my own personal experiences with my mom, it was very clear it wasn't what I wanted it to look like. And I think if we think about palliative care, its role is to fill those gaps, right? So if the oncology team is doing a great spiritual assessment and emotional assessment, and what the gap is pain management, great. What palliative care will do will fill that gap. So but it starts with what we believe people should deserve, and people deserve whole person, attentive, compassionate care. So I say it's the care that you deserve at the time that you want. And what I mean by that is oftentimes people get that very comprehensive care, but very, very late in their disease journey. Hospice is a good example of that, right? Hospice, people generally really like hospice. And then they ask the question, well, why couldn't I have gotten this earlier? So it's care that's maybe home-based or centered around where people live. It's care that takes the patient, the caregiver as the unit of care. It's the care that is highly compassionate and starts with someone's humanity and works outward from there versus their biology. And so, it's the care people deserve at the time they want. And so really the accessibility and the upstream nature of it is getting to this issue of when people need and want it, and defining what we know people deserve as human beings. And again, it's tailored for sure, but it's saying that people want to be heard and understood. They want to be treated as individuals. They want to be seen as a whole human being, not just a disease. They want to be called by their name, not by a number, right? These are very clear principles that we have. So when I explain it to that way to patients, they're like, oh, I want that. Yeah, I want the umbrella, not the rain. I want the extra layer of support, and I want the care I deserve at the time I want. I want that. Now let's define what that looks like for you in a way that's, open-minded and growth-oriented and curious, right? And I think that's why palliative care does so well. But frankly, those lessons can be used across many other aspects of healthcare delivery too. And I think as palliative care ascends in the complexity of who it takes care of, what it's going to leave behind is those principles now scaled and disseminated to all other parts of healthcare. And so I think fundamentally palliative care is about delivery of good care, but it's also about educating and supporting others as well, so that what we would have seen as a consult 10 years ago would not be seen as a consult today. And what we see today may not be what we see 10 years from now, because in our wake, we have left, an ecosystem and infrastructure where the rising tide lifted all boats. And even though our boat might sail to a slightly different sea to take care of something slightly more complex, we still left the tide high where we came from, right? And I think that's embedded in what we need to do.
It was a true pleasure to discuss these topics with you. I would also love to have you back to hear more about your initiatives as Chief Patient Officer, how we clinicians can better meet the patients at their lives and communities. So thank you so much. I hope we can have a follow-up chat in the future. If our listeners want to find you, we will leave the links on the show notes. And again, thank you so much for joining me for this conversation.
Absolutely. It was such a pleasure. Thank you.